You don't need the volume here? Very good morning, and I'm sorry about the delay today. So we're going to discuss some few OSCEs on common neonatal equipment that we use in NICUs. Welcome to this session today. I'm Dr. Aparna. I take care of the Neonatology division at KIMS Cuddles Kondapur. So we'll begin with some common equipments that we often see in neonatal ICUs. This is not only a question-rich area, but in terms of clinical application also, this is something that as residents, as pediatricians, we all should know. And we shouldn't be completely reliant on the biomedical engineers or the technicians for managing our equipment, because basic troubleshooting is something that all neonatologists, intensivists need to know. So we'll begin with some common equipments that we use. Each equipment will be followed by a few questions, and we'll discuss the answers. So we'll begin with the radiant warmer. Common questions here are what are the different modes. So the different modes of radiant warmer are the manual mode and the servo mode. In the manual mode, you set the heater output. Irrespective of the baby's skin temperature, the radiant warmer emits a certain heater output as 10 to 100%, and you can adjust this based on the baby's temperature. The servo mode is a mode wherein we set the desired skin temperature, and based on the baby's targeted temperature, the radiant warmer automatically adjusts the heater output in order to reach the set temperature. The next question is, when would you prefer to use a manual mode? So we prefer to use a manual mode whenever we don't have the access to the baby to kind of target the set temperature of the baby's skin. So often when we are awaiting the baby's admission from the labor room during the resuscitation, when the baby needs rapid rewarming for hypothermia, or when the baby has fever, when the skin probe can falsely detect a high temperature, we use the manual mode. Now, the heater output or heating element in the radiant warmer is made up of quartz or ceramic. Some things about disinfection. Disinfection of the radiant warmer is generally recommended using 2% basil acid or glutaraldehyde. We must never use alcohol, especially over the panels where there is a display. In terms of the precautions when one uses manual mode, the common precaution is that in manual mode, since we don't really look at the baby's skin temperature must be frequently monitored at least once in 10 to 15 minutes in order to prevent accidental hypothermia. What are the different alarms in the radiant warmer? So often different alarms include alarm because of the significant difference between the set temperature of the baby and the actual temperature. There can be alarm because of the power failure, because of sensor failure, and it can automatically alarm once in 10 to 15 minutes, especially when the radiant warmer is on the manual mode. Now, does radiant warmer have advantages over the incubator? Some common advantages that the radiant warmer has include easy access, wherein we can monitor the baby, inspect the baby more often, we can examine the baby more often. There is also a certain ease of doing procedures, ease of doing resuscitation. There is better monitoring that is available for the baby's clinical status. Lesser risk of infections is one of the putated advantages, although even with incubators, if we take adequate precautions, and asepsis infection should not be an issue. And radiant warmers are obviously cheaper than the incubators. Now, when it comes to the second common equipment that we use for the maintenance of temperature, that is incubator. Common questions here are, what are the modes of functioning of an incubator? The common modes are air mode and skin mode. In the air mode, we set the desired air temperature within the incubator, whereas in the skin mode, we set the desired skin temperature of the baby. Thermoneutral zone is a concept that we all should know. So thermoneutral zone refers to a range of ambient temperatures or environmental temperatures within which the baby is said to maintain normal temperature range. And beyond the maximum margins of the thermoneutral zone, the baby can have either high or low temperature, provided the baby is not able to adjust the baby's metabolic rate. In other words, within the thermoneutral zone, the baby can maintain euthermia with the least possible expenditure of metabolism, whereas outside the thermoneutral zone, the baby may have an increase in basal metabolic rate. At the expense of this increased metabolic rate or oxygen consumption, the baby can still maintain the temperature. Whereas there is another targeted temperature range, which is called as thermoregulatory zone, beyond the ends or margins of which the baby may not be able to maintain normal body temperature, even at the expense of additional metabolic energy. Now, the advantages of double-walled incubator include lesser radiant heat loss, indications of using incubator for thermal care. So there are various indications, especially for babies less than 30 weeks or babies less than 1,200 grams and babies who require humidification because of increased insensible water losses, such as babies born less than 28 weeks. The incubator offers particular advantages over the radiant warmer. The babies may also benefit from having an incubator during transport and for the purpose of isolation and in setups where there is low ambient temperature. The next question is about indications for using, I think we discussed that, advantages of incubator over radiant warmer. Some of the important advantages are that incubators help in reduction of insensible water losses and also provide humidification. So we move on to the next important equipment, which is pulse oximeter. So here we'll discuss the principle and applications of pulse oximetry, situations in which it is not very reliable, and about alarm limits, saturation screening for congenital heart disease, some additional parameters that we can get from the rainbow set pulse co-oximeter, and we'll discuss about perfusion index. So we all know that pulse oximeter meters work on Beer-Lambert law. So this is a law that helps us to calculate the concentration of an analyte based on the absorption of a certain wavelength spectrum as light passes from the light emitting part of the electrode till the light receiving electrode. So we place the emitting and the receiving electrodes on either side of the limb over which the saturation is to be measured. And based on the proportion of absorbed spectrum of wavelength, we can kind of infer what is the saturation. So this figure represents the how the reduced and the oxygenated hemoglobin have different absorption spectrums. In contrast to oxygenated hemoglobin, which has an absorption spectrum at 940 nanometer, the reduced hemoglobin has an absorption spectrum at 660 nanometer, which means red light of the visible wavelength spectrum has an affinity for the reduced hemoglobin, whereas the oxygenated hemoglobin has a natural affinity for the infrared wavelength with a peak at 940 nanometers. So based on the proportion of red and infrared light in the receiving electrode, that is based on whatever is emitted, the saturation or the percentage of oxygenated hemoglobin in the blood is calculated. Now, these are the following discussion point. Pulse oximetry is often referred to as the fifth vital sign. It is often used for monitoring the baby's saturation and vitals during resuscitation, for titration of oxygen during oxygen therapy. So ideally, whenever a baby is on respiratory support, it should be with saturation monitoring. It can be also used as an apnea monitor during transport and for screening for congenital heart disease. Some of the important limitations of saturation monitoring include the low perfusion states like shock and hemodynamic disability, or dyshemoglobinemia, carboxy or methemoglobinemia, where saturation monitoring pulse oximetry can have some limitations. The presence of dyes and pigments, especially nail polish over the baby's nails, can interfere with pulse oximetry. Optical interference because of bright ambient light, such as in phototherapy, also sometimes can be an interfering factor, and so also with movement artifacts. It can also be a problem with poor discrimination at the lower and upper end, especially at the upper end of the saturation spectrum. So whenever saturations cross 94%, we can never predict how high the PaO2 levels are. It can be anything more than 75 millimeters of mercury. It can go up to 100, 200, 300 millimeters of mercury as well. Some more questions. So a difference between pulse and co-oximetry is that co-oximetry also accounts or measures the methemoglobin, cyan hemoglobin levels apart from oxygenated and reduced hemoglobin. So it is also a precise tool for measuring the abnormal hemoglobins. The principle behind pulse oximetry is, of course, Beer-Lambert law, and 4 conditions in which pulse oximetry would be less reliable include poor perfusion states, dyshemoglobinemias, optical interference, and movement artifacts, as we discussed. Now, lag monitor phenomenon is a phenomenon wherein a fall in PaO2 or desaturation can precede the fall in saturation, and hence there can be a delay in picking up hypoxemic episode. SET technology is signal extraction technology, which is available with the Mesimo pulse oximeters. What is its advantage? It enables saturation accuracy during the low perfusion states, such as shock, and also during movement and noise artifacts, because it is supposed to have 5 algorithms versus a typical single algorithm as seen in regular pulse oximeters. So the pleth variability index depicts the changes in perfusion index during a respiratory cycle. It is one of the other useful parameters that is available in pulse oximeters. PI per se, or perfusion index, is the ratio between the alternating current or to the direct current. I think we have a slide on this, yeah. So these two represent the pulsatile and the non-pulsatile component of the infrared signal, which in turn correspond to the arterial and the non-arterial, that is the venous and the tissue component of the absorbed saturation spectrum. So PI is indirectly a measure of the perfusion of the limb, and it has been used as a useful marker for shock and congenital heart disease and low perfusion states. An elevated delta PI is also been evaluated as a marker of HSPDA in preterm infants. Pulse oximetry is also now being recognized as a screening tool for critical congenital heart disease. This is a flowchart that represents the action points based on pulse oximetry screening, which is usually performed at after 24 hours of postnatal age or just before discharge. Saturation screening with pulse oximeter is supposed to have failed if the baby's pulse oximeter from either limb is less than 89%. The screening is performed by connecting the pulse oximeter probe to the right hand, which is preductal, and either foot, which is postductal limb. So if saturation in any of the limbs is 89% or below, straight away this is called as failed screening, and the baby requires to be screened with echocardiography. If saturation levels are between 90 to 94% for persistently 2 to 3 records at 1 hour interval, again the baby has to undergo pulse oximetry screening. Or if the difference between preductal and postductal saturation is 4% or more, a baby who has a pulse oximeter reading of 95% or more in the right hand with a difference between the pre-postductal sats less than 3% is said to have normal pulse oximetry screening and is considered to have passed the pulse oximetry screening. So this is a useful tool for screening for congenital critical heart diseases. The rainbow set pulse oximeter or co-oximeter, in addition to regular saturation measurement, can also give us additional parameters like total hemoglobin, oxygen content, methemoglobin levels, pleth variability index, in addition to carboxyhemoglobin. So if we want to measure the levels of abnormal hemoglobins, in addition to pleth variability index and in addition to total hemoglobin and oxygen content, then we should be resorting to the use of rainbow set co-oximetry. The other useful important equipment that we use is a non-invasive blood pressure monitor or NIBP monitor. The formula for calculation of MAP or mean arterial pressure is very critical. This is represented by DBP or diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is the difference between systolic and diastolic blood pressure. The principle for use of the NIBP monitor is oscillometric technique. NIBP is usually more than the invasive blood pressure by 3 to 5 millimeters of mercury. So in a baby with hypotension, the NIBP can falsely overestimate the blood pressure and can masquerade shock in the initial phases. The pulse oximeter, the monitor, multipara monitors come in for 5 different sizes, the BP cuffs, and these are the different cuffs. The choice of the cuff to be chosen for baby's blood pressure measurement should be that the cuff bladder should completely encircle the arm and certainly the artery. We should make sure that 80% of the baby's the length of the mid-arm circumference is encircled by the cuff. While measuring the blood pressure, we should inflate the cuff for the bladder pressure to 15 millimeters of mercury above the systolic blood pressure and deflate slowly at 2 to 3 millimeters mercury per heartbeat in order to measure the blood pressures. And mean arterial pressure is the most reliable measure in the invasive blood pressure monitoring. So invasive blood pressure monitoring uses a pressure transducer that directly measures the pressure, whereas non-invasive blood pressure monitoring is based on oscillometry. This is a CPAP device, and here we are seeing a bubble CPAP device. So questions here are, what are the different types of CPAP? We have constant flow and variable flow CPAP devices in general. Constant flow devices can further be categorized as bubble CPAP and ventilator CPAP. Bubble CPAP is a system wherein the heated humidified oxygen air mixture, which is kind of mixed based on the set fractional inspired oxygen concentration, after getting appropriately heated and humidified to 37 degrees and 100% relative humidity, passes through these circuits and is provided to the baby using a nasal interface, and the expiratory limb is dipped in underwater seal in order to deliver a certain pressure. And the ventilator CPAP, on the other hand, uses the expiratory flow valve as a mechanism for pressure resistance. So these are the different parts of the underwater bubble CPAP device: the blender, the flow meter, the heater humidifier servo control mechanism, the patient interface, and the underwater seal. The other type of CPAP is a variable flow CPAP, wherein we have again different types like infant flow driver CPAP or CPAP. In this type of CPAP, we have two different flows operating, one higher flow during inspiration and lower flow during expiration. And the principle of flow driver CPAP is the Coanda effect or the fluidic flip mechanism, wherein the nose piece of the infant flow driver is kept connected or open to the atmosphere. Whenever the baby inhales, there is an additional flow of gas that is entrailed from the atmosphere, and whenever the baby exhales, some of the ventilated flow can be flipped back to the atmosphere, which is also called as fluidic flip. There are some additional knobs in the bubble CPAP inspiratory circuit. There are three arrows that are indicative of these knobs here. And the first knob refers to the pressure relief valve. The second knob is a knob that is connectable to the pressure manometer. And the third knob is the one that is used for the connection to the oxygen analyzer. Now, oxygen analyzer is a device that is used for measuring the delivered oxygen concentration to the baby as against the set oxygen concentration or FiO2. Just like we have an oxygen analyzer for measuring the delivered FiO2, we also have a flux meter, which is a device for measuring the delivered phototherapy spectral irradiance. So the clinical utility of a flux meter is to measure the spectral irradiance of the phototherapy unit. Ideal range for the phototherapy emission must be 450 to 460 nanometers. The readings are interpreted by calculating an average of the 4 flux meter readings, irradiance readings taken from the corner of the phototherapy footprint and taking an average. Intensive phototherapy refers to provision of at least 30 lux or 30 microwatt per centimeter square per nanometer spectral irradiance, and by exposing the maximum surface area of exposure of the baby. Now, therapeutic hypothermia devices. The indications, as we all know, are babies who are born at more than equal to 36 weeks gestational age with birth weights more than 2,000 grams, with an APGAR score less than or equal to 5, or babies that require continued resuscitation even by 10 minutes of life, with the presence of cord blood acidosis defined as a pH less than 7 and base deficit more than 16 within 60 minutes of life. Along with these criteria, it is also essential that we demonstrate evidence of moderate to severe hypoxic encephalopathy in order to kind of categorize the baby as a candidate for therapeutic hypothermia. We exclude generally babies who are more than 6 hours at the time of admission, babies with major congenital abnormalities that require surgery, and babies with chromosomal abnormalities or syndromes. There are high-tech devices for cooling, which come with servo control mechanism like Blanketrol or Ticotherm or Criticool that have inbuilt temperature monitoring for core temperature monitoring. Usually, we use either the rectal temperature monitoring or the esophageal temperature monitoring. We may also have some low-tech devices like used for low-tech cooling, like water bottles, natural cooling, fans, and gels, as well as phase-changing mattresses. Mechanisms of therapeutic hypothermia include reduction of the brain metabolism by roughly 5 to 7% for every degree centigrade of core temperature reduction that is achieved. It also works by reduction of glutamate-mediated excitotoxicity and upregulation of cell survival pathways and limitation of the generation of reactive oxygen species. So by mitigating most of the mechanisms of pathogenesis of asphyxia, therapeutic hypothermia would work. These are the three devices, the three important randomized controlled trials, which gave us substantial evidence for recommending therapeutic hypothermia, and it is ineffective without good supportive care in the form of control of convulsions and inotrope support for hemodynamic instability. The next device that we shall be discussing is the TCB, Transcutaneous bilirubinometry, which works on the principle of spectral reflectance of bilirubin from the skin, wherein the the light that is the optical wave that is guided in or delivered into the skin is reflected back, and based on the level or the concentration of bilirubin, the absorption can vary. So the common sites for measurement of TCB include forehead and sternum, but TCB comes with some inherent limitations, although it has the potential for reducing blood sampling losses. Inherent limitations of transcutaneous bilirubin assessment include its lack of precision or lack of agreeability in preterm infants with clinically significant jaundice born less than 35 weeks, although there are more and more papers coming on agreement of TCB and TSB values even among preterm infants. However, there is very little evidence for now to recommend TCB measurement for babies less than 24 hours of postnatal age and babies with significant hemolysis and other risk factors like ABO-RH isoimmunization, and term babies where the TCB reading is greater than 250 micromoles or greater than 17 milligrams per deciliter. So this is what we just discussed. This is TCB. The principle is spectral reflectance, and we discussed some of the limitations. So this is a case scenario. We see a deeply icteric baby with a serum bilirubin level which is above the phototherapy zone and no features of bind. The next step will be to start the baby on intensive phototherapy, which means the baby should be started on dual surface phototherapy, covering maximal surface area of the skin as possible, limiting the diaper area to the smallest possible area and a small eye bandage, and exposing the baby to the maximum spectral irradiance for the longest possible duration, and ensuring adequate hydration in the form of enteral feeding or in the form of intravenous fluids, whichever is appropriate based on the clinical stability. 3 steps to increase irradiance during phototherapy include adding additional phototherapy units, maximizing the surface area of skin that is exposed, and shortening the distance between the infant and the phototherapy unit, and also some role of adding additional white slings or reflector cloth around the baby. The term intensive phototherapy as recommended by AAP refers to provision of at least 30 microwatt per centimeter square per nanometer wavelength, and MRI evidence of bilirubin encephalopathy would be in the form of increased signal intensity on T1 weighted imaging in globus pallidus and PLIC. Phototherapy is one of the commonest interventions that we provide to newborns, and there are different mechanisms by which it acts, like configurational isomerization the mechanism by which the bilirubin isomers are converted to water-soluble isomers. Structural isomerization is the most effective and irreversible step of phototherapy, wherein bilirubin is converted to lumirubin, and photooxidation is probably the least important mechanism of phototherapy. Different types of lamps are available. These are the compact fluorescent lamps or CFL lamps, which are slightly outdated now. They were also called as special blue lamps or Philips TL52 lights. These are 20 watts bulbs that emit light with a broader kind of wavelength range between 400 to 520 nanometer. They also emit a lot of heat in the process. The blue LED lamps, in contrast, are power efficient. They do not emit much heat and they last for at least 10,000 hours. Tips for effective phototherapy include placing another phototherapy unit beneath or beside the neonate, placing reflecting material around the incubator or the radiant warmer, and keeping the diapers as short as possible. Also, keeping the phototherapy unit as close as possible for up to 15 centimeters is something that is recommended for newborn babies. Side effects of phototherapy include dehydration, fever, retinal damage, increase in cerebral blood flow, and photooxidative side effects. Now, these are syringe pumps. These are common equipment used for providing intravenous fluids at precise volume rates to babies. There are different types of infusion pumps, including gravity-controlled drip rate regulators and the positive displacement pumps, of which volumetric pumps and syringe pumps are the commonly used devices. Syringe pumps are positive pressure displacement devices which use positive pressure for kind of providing fluid rate at a precisely regulated volume. And they may also alarm when there is occlusion to the limb or when the infusion is about to complete or when the infusion is already completed. So this can be useful for nurses to promptly identify and suitably replace the syringe or change the intravenous line if there is extravasation. Before we close, some of the newer equipment that we have, AEG or cerebral function monitoring, which is also called CFM. AEG or amplitude integrated EEG is different from conventional electroencephalogram by means of using biparietal leads, two leads in addition to the vertex and grounding lead for the measurement of the electrical activity of the baby's brain. There are various patterns that we use in AEG, which include I think it comes here. The normal trace, wherein the lower margin is above 5 and the upper margin is more than 10 microvolts. So this is called as normal trace continuous pattern. Whereas if you have the lower margin going below 5 microwatt, even if the upper margin is normal, it is called as discontinuous normal voltage pattern. If the upper margin also drops to less than 10, it becomes discontinuous low voltage pattern. So these are considered as moderately abnormal, whereas an isoelectric pattern or a burst suppression pattern in EEG, wherein both the lower and the upper margins are completely depressed with occasional spikes, high voltage spikes that may reach 50 to 100 microvolts, are considered to be severely abnormal. So AEG is different from conventional EEG in terms of being amplified, and it is rectified electrical discharges. It is also kind of filtered because the electrical discharges beyond 15 and less than 2 volts are usually filtered out. And it is also placed on a semi-logarithmic scale in contrast to a linear display as in the conventional EEG. Now, how does it help us? We can look at the pattern of the AEG, and we just saw how it is classified. So we need to look at the upper and the lower margin as well as the sleep wave cycling to identify the pattern of CFM or AEG. The AEG patterns help us to kind of identify whether the baby has a normal versus an abnormal background activity, and this is the most important utility of amplitude integrated EEG. It is not a very sensitive tool for picking up seizures, especially seizures from the deeper parts of the brain, which is often missed by the AEG recording, and brief or focal seizures can be missed by a amplitude integrated EEG trace. So early EEG helps us in identification of hypoxic encephalopathy, and this can be a very useful tool for picking up newborns who can benefit from therapeutic hypothermia as an intervention. It can also help us in classifying the severity of asphyxia and initiation of therapeutic hypothermia, and in monitoring the response to anticonvulsants. Normalization of an abnormal AEG pattern by 48 hours is also an important prognostic marker of a potentially near normal outcome. Another ventilator-associated equipment that we shall be discussing today is a flow sensor. We shall not be discussing about ventilator per se because it itself is a huge topic on its own. Now, there are different types of triggering mechanism. The first two on the left side, the thoracic impedance meter and the Graspe capsule, which is abdomen inclination tonometry, both rely on chest and abdomen movements respectively for sensing the baby's respiratory efforts and to trigger ventilator inspiratory breaths. The next two, the differential variable orifice meter and the hot wire anemometer type of flow sensor, are both used for detecting the baby's inspiratory flow as a means for triggering ventilator breaths, and the pressure transducer can sense the baby's negative inspiratory pressure generated during the respiration as a means for triggering ventilator breaths. Among these different types of triggering mechanisms, the flow sensor has least response time and measures the tidal volume, but is associated with an occasional problem of auto-triggering or auto-cycling. So I shall conclude this presentation here. We have discussed some commonly asked questions in neonatal equipment. This is something that is often asked not only in the exams for postgraduates, but is also of utmost use for practicing pediatricians who work in NICUs for common troubleshooting. Thank you so much, and looking forward to meet you all in the next session next Friday between 2 to 3.